Good afternoon, everyone. Once again, a warm welcome from Team ARC. So today we'll be starting the fourth session of Think Under the Apple Tree. I request our chairperson, Dr. Mohan Rajan sir, co-chairperson, Dr. Ashok Kumar Nanda sir, Dr. Nanda sir, to please join us.
Nanda, come.
Can we have the judges, Dr. Santosh Bhide, Dr. Rajiv Kumar Gupta sir, please. Dr. Kuresh Maskati sir is there.
Hello, how are you?
Dr. Ragini madam. Dr. Colonel K. Shyam Sundar sir is here. Okay. So we'll start with the four judges. Shyam Sundar sir.
Sham, come. Hi, Sham.
कुर्सी लगा और एक
Fine.
कुर्सी है उधर हाँ कुर्सी है okay so we have a excellent set of 5 judges here. Dr. Santosh Kumar Bhide, Dr. Rajiv Kumar Gupta, Dr. K. Shyam Sundar, Dr. Mohan Rajan and Dr. Ashok Kumar Nanda. So without wasting much time, we'll go on to the first presentation. The first presenter, are you ready? Dr. John Davis Akara. So he'll be presenting on Synoptophone, the 3D pocket smartphone stereo acuity test. So next presenter, do we have Dr. Ashok Sharma here? Yes. Dr. Aniket is here. Dr. Savleen Kaur is here. Yeah. Dr. Raju Sampangi, I am seeing him. Dr. Brinda. Yes. Dr. Pratik Sehrawat. He's there. Oh, okay. Dr. Gopal Pillai. Dr. Gopal Pillai. Dr. Sheetal. Dr. Shweta Walia. Okay, so almost all are present, so let's go on time. Reset the timer. Your presentation starts now, John.
My presentation is Synoptophone, stereopsis testing with a smartphone, virtual reality and anaglyph. So we know what is a 3D photo, and these are called wigglegrams. These are 3D photographs which wiggle between the left and right image. And we know that stereopsis is very important for motor skills and driving and so many other things. And stereopsis testing is often ignored because most ophthalmologists do not have access to stereopsis testing tools, mostly because they are very expensive and mostly because there is not much interest in stereopsis testing. So these are the tests for stereopsis which are available: the titmus fly, the random dot test, the butterfly test, and all these tests. These are all based on random dot stereograms and polarization of light. Then there is a bunch of tests. The first one here, the Bernal evaluation, is based on lenticular films. And then you have the anaglyph test. The anaglyph tests use red and green in this case to split the images between the two eyes. So that is another way to look at 3D, and that is a much cost-effective method to look at it. But all these tests are still very expensive, and maybe you have seen stereograms, which are images which look like just modern art, but when you focus your eyes correctly, you can see the 3D image pop up. So using these principles, I've started making an app on which can be used to test stereopsis. These are random dot stereograms. So this app uses random dot stereograms as well as anaglyph stereograms. So anaglyph stereograms can be seen with the red-blue glasses. So these glasses are for looking at the anaglyph stereograms. If you wear these glasses, what looks like a random bunch of dots can actually reveal the hidden 3D photo in between. So if you have good stereopsis, you can see the picture. So here it would be, I guess, it's a triangle here, I guess. I mixed it up on purpose, and a square here. So you can see this hidden image only if you have good stereopsis. And this is how I built the app. I used a free app building service called MIT App Inventor, and with that I made an app, and this is what the app looks like. So this is the first screen of the app, And I'll just open it also for you here. So it has all the basic principles of stereopsis, binocular single vision, so fusion and stereopsis, and this is the TNO test, and this is the Randor test. So this is the one which is most useful. So this will show a hidden image, and the person who is being tested had to wear the red-blue glasses and look at the image and say what is there. So there are 4 buttons indicating the 4 different options which can be present, and once you press it, it tells you whether you're correct or wrong. So if you get it correct at least say 5 times in a row, that way you can assure that the person is not guessing and they are able to see clearly. So that is my app which I developed for stereopsis testing, Synoptophone. Thank you.
Thank you, John. Can I ask judges one question, please?
How do you grade the stereopsis? How do you grade what?
So
What is the this thing you have marker for grading?
So you have to measure the stereopsis in milliseconds of arcs. So right now these tests of which I put all the images are 300 milliseconds of an arc. If you put different images of different grades of stereopsis, you can go at finer and finer stereopsis until you can stop at where the patient can see. So this one right now is just yes or no at 300
Yes or
milliseconds.
no only.
Right
Yes or
now
no.
only yes
You're
or
not
no.
able to grade that.
We can
Develop it
improve the app to add the extra features. This is the prototype model which I completed developing today. That is why it is not having the gradation.
Thank you. Thank you, John.
Thank you,
Request Dr. Santosh Bide to please hand over the certificate to John Davis Sakara. So can we have the next presenter, Dr. Ashok Sharma, on the stage, please?
Rubber band निकल गया.
Sir, that side, please.
Friends,
So, Dr. Ashok Sharma will be presenting on the hybrid keratoplasty, that is combined DALK and penetrating keratoplasty for extreme ectasia in post-graft advanced keratoconus. Oh, your
Thank
time
you, sir.
starts now. Over to you, sir.
Good afternoon, everybody.
of 29-year-old female who have undergone PKP for advanced keratoconus in the right eye 5 years ago. She presented with poor vision, opaque graft, extreme ectasia, and thinning of both the host cornea and graft. It was impossible to rehabilitate as both PKP and DLK were not possible. Suddenly, an idea struck. Why not combine the two, peripheral DLK and central PKP? Partial corneal trephination was done using an 11.0 millimeters trephine.
So these cases are very difficult to manage because both host and
The incision was deepened. Lamellar dissection was initiated using a Pauphite knife.
and the lamellar dissection in thin cornea is extremely difficult. So we use all instruments which are available with us.
Lamellar dissection was performed using a lamellar dissector and corneal scissors.
Peripheral, very thin cornea, several procedures have been described. But in this case, we thought we'll try to do the lamellar dissection as deep as possible so that we can put the donor graft and we have
The
to
lamellar
take care.
dissection was completed up to the host graft junction.
And once we have completed that, we thought we'll put some fibrin glue so that
Fibrin glue was put on the lamellar dissected corneal surface.
these are the two components of the fibrin glue. And once we put the second component, after waiting for a minute or two, you can see that the fibrin glue has polymerized, forming a gel. We wanted to make sure that the peripheral lamellar corneal graft
AC
area
was entered at host graft junction with 15-degree knife. Opaque graft was excised using corneal scissors.
because there was no other way to take care of this patient when there is extreme thinning of the peripheral cornea
A full
along with
thickness
the
donor corneal button 11.0 millimeters was secured. Ten monofilament interrupted sutures were used.
We do use continuous sutures in cases where we are doing penetrating keratoplasty or lamellar keratoplasty of 7.5 millimeter diameter. When it comes to the very large corneal grafts, like in this case, we want to be very sure of the apposition, so we have chose to put interrupted sutures along to make sure that there are no areas, weak areas where we have to
Corneal topography showed significant flattening.
OCT shows that the lamellar part is well adhered, and topography shows that the cornea has flattened in the central part, and we could achieve
The
good
patient
results.
had a clear graft and achieved 624 BSCVA. It was like conquering an indomitable peak in the Himalayas.
Thank you.
Very nice.
Thank you, sir. Judges, question, please.
How many patients have you operated on with this?
So we have done this kind of keratoplasty for several cases, but for advanced keratoconus and PKP, this was the only one. We have not got the second, but we have done it for acute hydrops patient also, where it was a very large hydrop, and we have to do surgery early because of the child was having amblyopia also. So we have done, I think, 3 or 4 cases like this.
Have you published this?
Yes, sir.
Have you published this masking?
Yeah, it's ready for publication, sir.
Ready for publication,
Yeah.
but first time ever, anybody else has done it before.
So we are going to publish it.
No, anybody else has done it before? Has anybody done it before? This combination of DALC and PKP. That's what. Very good.
Thank you, sir. I request Colonel, sir, Dr. Sham Sundar, to please hand over the certificate to Dr. Ashok Sharma ji. Now we have our next presentation from Dr. Aniket Jinodia. So he'll be speaking on the minimalistic approach.
The minimalistic approach.
Good afternoon, everyone. Thank you, APAO and AIOS to give me this opportunity to present.
I don't have any final say.
Hello.
Go ahead, please.
Just like how one dumbbell can be used for multiple exercises, in the similar way, one instrument can also be used for multiple steps in phacocataracts surgery. In this video, I will be showing you all how I replaced few instruments with just one instrument during surgery. As it has been said that scarcity breeds creativity. This idea came in my mind when one of my instruments ended up falling on the ground and other instruments were not sterilized at that time. Let's come to the surgical video. This is a case of grade 3 leathery cataract. I used keratome blade for side port making, capsule stained and washed, followed by visco injection, cystotome used for access, main port made, followed by hydrodissection. I used the same cystotome for nucleus rotation. Now it's time for the phacoemulsification. Again, I use the same cystotome in place of chopper. 4 quadrants were achieved with the help of cystitome without much difficulty and stress on the granules. Each by emulsified, IA done, followed by IOL implantation under hydro. Wound hydrated. Coming to another case, I did the same in mature cataract case also and achieved similar result. Rhexis with cystitome, nucleus rotation with cystitome, direct chalk with cystitome, one pi emulsified followed by emulsification of the rest of the quadrants, IA and IOL implantation done under hydro. Here I use the same cystitome for dialing the IOL in the back. Unhydrated followed by the intracameral antibiotics. In this picture, I have tried to show and compare the measurement of the tip of the Sinskey hook, chopper and cystitome. So, my objective to present this minimalistic approach surgical video was to let you all know that one cystitome can be used as a substitute of different types of chopper and can be used in different types of cataract if used in a correct and controlled way. This can also be a cost saving technique. These are the main instruments used in my surgery along with the phacoemulsion instruments. Thank you.
Thank you. Actually, two case was more there because of time permit. I just cut that two case more.
Yeah, you have excellent surgical hand. I will congratulate you for that.
Thank you, sir.
But which machine you are using?
Any machine, sir. I used
The videos were shown on which machine? Was it Centurion
Centurion, Legion,
and
both.
Legion? No? So
Yeah,
those
both.
are high-end machines.
Yes,
So you
sir.
are talking about minimalistic approach on high-end machines, and the cost of surgery is on FMS, what we used for Centurion or that. So, and it is very risky to use cystitome. Even for dialing the lens, you are using cystitome. It's very risky for a common surgeon. You are a gifted surgeon,
No,
probably.
sir.
You have an excellent surgical hand, so there is hardly
Sir,
any
actually I
chance. But
tried in
otherwise, there
wo-
is a risk of capsular rupture, accidental. So, why take such risk?
So if you
Even
if
you can accidentally puncture the CCC edge
Yeah.
because of cystitome. It's most common.
I know, sir, but if
Actually, I was surprised how come that has, because with Sinskey's hook, you can manage 90% of the cataract. You can crack 90% of the cataracts with Sinskey's hook. So that may be a minimalistic approach, but
so in
excellent surgery.
most of the time we use the IA cannula to put the IOL in the bag. In some cases we may require. So I just, because of this minimalistic approach, I did it in some cases, and till now I did more than 140 cases, and in different cases, small pupil, PSC, PPC, and I received the same results. So if it's in the controlled way, we can.
Only problem is little brown cataracts will not be able to open.
It first was the
Yeah,
sir,
yeah,
is
that
the
is not
leathery
very brown.
cataract.
It's grade 2 only.
Uh,
Brown, I'm talking about grade 4, 5 and all, no? Because the cystitome is a little fragile when compared to a chopper.
okay, sir.
So you need a little more stronger instrument for you to go in and open it up in the posterior nuclear plate. But anyway, it's a very good lateral thinking and good innovation, I would say. Hats off to you. Yes, yes. Yeah.
Okay. Thank you.
No, no, sir.
Thank you, Niket. I request Dr. Rajiv Kumar sir, Gupta ji, to please hand over the certificate to Aniket Jinodia, please. Here. So we have our next presenter, Dr. Savleen Kaur, on quantification of strabismus using the deep learning methodology. So over to you, Dr. Savleen.
A very good afternoon, everyone, and thank you very much for inviting me here. So I'm going to be talking about strabismus, and I would like to ask you, the audience, what is the first thing that comes in your mind when you hear the word strabismus? Anyone? I don't have much time. So the most common answer that I get, it's difficult. Some people like to call it boring. And if I beg your pardon, but the judges might say, go to the next talk because we don't want to hear strabismus.
Okay.
So we are left a handful of very dedicated pediatric ophthalmologists in the country. In fact, only 11 centers that offer a fellowship in pediatric ophthalmology. It's one of the least preferred branches. Even after doing a fellowship, people like to combine it with a cataract surgery in order to make our specialty a little glamorous. So what, as a result, is that even basic strabismus surgeries are performed at tertiary centers. It's a time-consuming branch, and there are difficult algorithms, and people often ask, what is the dosage that you operate on? The traditional diagnostic methods are based on cover tests. It requires clinical knowledge. What inferior oblique overaction I see, my fellow doesn't see. So it is limited by the uncooperativeness of the child coupled with the objectiveness that it has to the specialty per se. Concerns for the patient are manifold. This patient created my Instagram profile because she was so bothered with her strabismus after surgery, and I often quote her example because we forget how psychologically traumatic this condition might be. Job opportunities are less, and not to forget, it causes a large chunk of childhood blindness. Keeping that in mind, we wanted to integrate the use of AI into making a device that can detect strabismus, classify it, and also quantitate it. So what we did was we recruited about 300 patients of strabismus with a handheld and the smartphone camera. We took the same photographs by the same observer at a fixed distance, fed it to a machine, and trained the machine using YOLO and efficient NetB, which are convoluted neural networking. And the algorithm was trained to first classify strabismus and then to quantitate it. This quantification was based on Canthai recognition by the software, by the pupillary center recognition, and it has a lot of technological aspects to it, but by and large it involved input of a facial image. The machine kind of segregates it, segments it into an eye region, identifies the landmarks, and gives you a severity index, horizontal as well as vertical strabismus. To confuse you more, these are confusion matrices which actually told us that our algorithm was working 94 to 97% of the time accurately, and it was actually matching with the refractive errors that with the prism diopter readings that we were obtaining in the clinic, with the absolute error to the last table, 0.02. So it's a suggested method to objectify the readings. We have an algorithm which can tell you, using deep learning, what is the strabismus, the patient can use it, the surgeon can use it, and then you can quantify it, and it is no longer limited by the inter-observer variability because it has an AI component to it. It will facilitate our numerical assessment, and it will set the stage for further AI-enhanced ophthalmology in strabismus, also telling us dosages and what muscle to operate and how much to operate. The current status is that we have built the software, it's applied for a patenting. We are testing it on different age groups and building a hardware component onto it because we require some funds for it. We at PGI are collaborating with the Thapar Institute of Technology. Without this, it would not have been possible. And the future vision is to make it more scalable, more reproducible, add more and more images to make it better and useful for everybody at the community level, at the hospital level, and then even at the patient level. Thank you.
Very nice.
It's a nice idea, but who do you want this app? Do you think it'll
It's
help
not an
you in
app, sir.
training, or
It's not an app right now. It's an algorithm which is built into a device. At present, we are planning to use it in the hospital first to see whether you can have, say, a kiosk where the patient can, just take a photograph and it can tell you whether you require a referral or not. It can be used at centers which do not have strabismologists, then refer the patient, telling them that this patient might require surgery. And In the app, we were thinking make it for the patient so that if sometimes patients have pseudostrabismus and they think that they have it, so if the app can tell you, yes, you have a strabismus, then, but the app is not on our mind right now. The first idea is to make it for the hospital and for the clinician.
How many images you have given for that deep learning thing or for
Sir,
the machine learning thing?
It was divided into a 70-30 data set for training and for validation. So I had around 300 which the algorithm was trained on, and I've fed another 200 for validation for the quantification part. But I'm still in the process. of
How
doing
many
it.
normal
300
images?
is not good enough.
is
no?
not
It's not a good amount for
yeah,
deep
it's a
learning, yes.
less
But
less
it has
number.
never been done, sir, so it is the first time. We
Yeah.
are still into the process. We plan to do about 1800, and that's our...
How many normal images?
Normal,
how many
sir, when-
exo? How many ISO? That way.
so
I'm
I
asking.
do
Or
have that
vertical.
data.
Nahin,
So
just you can
mostly it
just-
was ISO and exos to begin with, by and large. So a rough number was that we fed 300 and then we had 182 controls to begin with. Then we added 200 more to validate. For validation, we did not put the controls because quantification did not require a control group. It's a normative.
Photos were taken on mobile.
This was taken on a 12 megapixel smartphone camera by one of our residents.
And from a fixed distance.
It was a fixed distance in a fixed room, but the algorithm is also made like that it standardizes. Even if you take it from some other phone, it will standardize, segment it, orient it, tilt it. Even brightness would be made uniform across the images so that before you quantify, you have a
And it can
standard.
identify head tilt also.
I would want to say yes, maybe in the next time I present this, but right now we are correcting the head tilt to get the strabismus, because strabismus will manifest once you are correcting the head posture.
Thank you.
Okay.
Thank you. Thank you,
Very
Dr.
nice.
Savleen.
Thank you.
I request Ashok Nanda sir to please hand over the certificate to Dr. Savleen Kaur. So we have our next presenter, Dr. Raju Sampangi. So he'll be speaking on the 3D digital video indirect ophthalmoscope and the oculoscope, the concept and the proof of the concept.
Koresh, you want to sit here?
Dr. Kaur, you can listen to my presentation. It might be helpful for you also. Good afternoon. Shall I start?
Or two of us can sit that side. We can move that side.
Shall I start?
Yeah, Dr. Raju, you can start.
We are all familiar with how binocularity is achieved in an indirect ophthalmoscope by using prisms or mirrors. The mobile-based indirect ophthalmoscopy is based on monocular indirect ophthalmoscopy, and the video indirect ophthalmoscope records videos in 2D. With so many options for fundus imaging available, why one more? What's different? What I'm going to present to you is a futuristic idea. It's a completely digital device with no optics of the ophthalmoscope being involved. What are the new possibilities? Well, you will be able to see an erect image. We can reinvert the image at the click of a button. Real-time teaching. Students can see the images in 3D as seen by the examiner in real time. And we may also be able to transmit the images remotely for management advice, especially for ROP. We can record videos in 3D. Not only this, we'll be able to see this on a very large screen, right in front of your eyes. As large screen as 201 inches of screen right in front of your eyes. Is this all possible? Yes. How can we do this? We can do this by using a twin camera system and a head-mounted near-eye display. So this is the concept device wherein you have the two cameras and the LED light placed close to each other, and the images from each of these cameras are transmitted to each of the eye. What happens is the right camera sends the image to the right near-eye device and the left camera to the left near-eye device. You can also have two more additional cameras set at 60 or 65 mm IPD, and using this, you can do record ophthalmoscopic oculoplastic examinations and squint evaluations, and with appropriate software, one can digitally overlay the scales of measurements, making these examinations accurate, recordable, repeatable, eliminating the subjective errors. And as told in the previous presentation, AI can also be used to automate these examinations. As a proof of concept, I funded and got these two devices, near-eye devices. I was an early backer for this Dream Glass, and using this, we are able to record the fundus images using the near-eye devices. And we also applied a patent for the concept. So this is how I would want the indirect ophthalmoscope to look like in future. With the Apple getting into the AR/VR game, mobile phones are likely to make a way out. 5G technology will allow rapid data transmission, allowing real-time data transfer, and camera sensor technology also is making huge strides. Using all this put together, if we can come together and create a device like this, it can be a game changer for the ophthalmic examination and teaching purposes. The form factor is going down so much that the near-eye devices are going to look like this in near future. And you'll be able to see the large screen right in front of your eyes to see the images, and can be used for even near-eye surgeries. All your surgeries, what you're doing, seeing a 3D screen, can also be used or can be changed to the near-eye devices. This is from Samsung. This is what is going to be expected in near future. So my conclusion is, this is one device with many possibilities. You'll be able to do not only the 3D indirect, but also use it for the stereoscopic view, point of view examinations, better training of postgraduates, simultaneous viewing, advanced examination for oculoplasty and squint is also possible, and we can also integrate laser into this device, making it a wholesome device for use in ophthalmoscopy in future. Thank you.
Very nice. What will be the cost, Raju?
The cost of this near-eye device, if at all, it's going to be around somewhere around 1 lakh, sir. 1 lakh to 2 lakhs is what is going to be the device. The Apple one is the costliest one. That's costing around 3.5 lakhs. But if you are going forward, I think the technology is going to become cheaper and cheaper as more players are getting into it. Only thing, if we come up with a better idea to integrate all of them, I think we'll be in a position to harness the technology.
Very nice.
Thank you, sir.
Thank you. Thank you very much. I request Dr. Mohan Rajan to please hand over the certificate to Dr. Raju Sampangi. Next, do we have Dr. Brinda? Dr. Brinda. Okay. So Dr. Brinda is going to present on, what's that? Prescribe. Do it yourself, e-log atlas for PGs and the fellows.
Good afternoon, everybody. We all know logbooks are the integral part of PG residency, but traditionally we use written logbooks. But a written logbook has legibility issues and limited storage, limited search option, and it is inconvenient to update and difficult to share. So in many institutes we are using e-logbook. Converting into an e-logbook has improved the accuracy of and efficient data entry is possible. There is search functionality as well as automatic backup, security and privacy is possible. And it is easier to share, especially in remote access. In ophthalmology, it relies heavily on the visual diagnostics. For an ophthalmic resident, it is very crucial to remember and interpret the images we come across in the OPD as well as camps. So that is how we attempted to revamp the traditional logbook approach to encompass clinical photograph with a concise summary of the case that we come across in OPD and camps. Initially, we used to take photograph with our smartphone, and later on, when we were used with the slit lamp, we collected images from the imaging system attached to the slit lamp, and also we used smartphone adapter to connect to the eyepiece of the slit lamp to get the images. And fundus images were collected from the fundus imaging system in our hospital. And in community outreach program, we used a 3D printed anterior segment as well as posterior segment imaging system and smartphone-based fundus cameras. And later on, we have a discussion with our consultant, and these were added into simple digital platforms like Microsoft PowerPoint. And we added annotation to improve the image. I would like to invite your attention to few pages of atlas we have created. Later on, we used to collect images even from the OT. We collected the pathological images from the lab associated with. Once the number were increasing, we divided it into anterior segment as well as posterior segment. For an easy access, we thought of developing a web app. We named it as Prescribe. We can log into the web app by making our account with the name, email ID, phone number, and whether, selecting whether resident or a consultant. On the home page, we are able to see all the cases we have uploaded so far. On the left-hand side, we will be provided with all the specialties, and clicking onto a particular specialty, we'll go into all the cases that have been uploaded under that particular specialty. And we can add a new case. On the My Atlas platform, we can see all the cases we have, the person has been uploaded, and on the right-hand side, for that particular cases we have added, we will be provided with edit option as well as a view option. We can add a new case by clicking on the add new option. We have to add the name, EMR number, and short summary with diagnosis. We have to select the specialty so that it will go into the particular specialty. We can add media from our gallery, and we have to save it. Once it is saved, on the bottom side there is a comment option where our consultants or mentor can comment. And on the left-hand side top, there is an export PDF option. We can take a PDF of the same, and we can save it, and we can even take printout of the same, whenever we need to present it for our Viva or exams. So converting a written logbook to an e-log atlas have encouraged our active learning, improved retention and recall, supported collaborative learning. It acted as a potential tool in our OSCEs and Vivas. And it facilitated objective assessment and feedback for the consultants also. So considering an e-atlas logbook will be, can beautifully merge the precision of a logbook with the richness of atlas. These are my references. Thank you.
Very nice.
So is this a private logbook or is it shared between residents?
Shared between residents, sir, within the hospital. Consultants.
Because when you had a physical logbook, if you attended 10 cataract surgeries or 20 cataract surgeries, that was recorded as your attendance.
Yes.
Here, if everyone is going to contribute pictures, you have the person who has clicked the picture's name.
Yes. We can see the picture, but only for that person who have uploaded it, we can only take a printout or convert to PDF or edit the option. Others can only comment.
They can see it.
They can see
it and
view
comment.
option is up.
But it remains your
Yes.
atlas.
I think it's customized to each and everybody. Yeah.
Okay.
Same patient is seen by another doctor, and he also uploads. Then that becomes his image.
We upload after the discussing with the consultants only. After final.
Okay, thank you. Thank you. I request Kuresh sir to please hand over the certificate to Dr. Brinda.
Yes, sir.
Call our next presenter, Dr. Pratik Sairawat. Thank you, sir. Thank you, Dr. Brinda. We'll go to our next presentation. Dr. Pratik will be presenting on the novel technique for efficient cutting of intraocular lens using phaco knife and its in vitro effectiveness.
Hello, good afternoon everyone. I'm Dr. Pratik Shirawat, and I'll be presenting the novel technique for efficient cutting of intraocular lenses using phaco knife and its in vitro effectiveness. Introduction. Well, broken eyes are uncommon but can occur to us all once or twice a year. These broken eyes can sometimes be very notorious during explantation and may cause complications like PCR, zonal dialysis, endothelial damage, DMDs, and can cause decentration if left in situ. Also, with the advent of the LASIK surgery and more patients adopting to LASIK surgery, errors in calculation for IOL may warrant for an IOL exchange. Well, the existing techniques for IOL removal are common methods are using the vanas or the micro scissors. Well, the challenges are maintaining the anti-chamber stability and the risk of injury to intraocular structures. Introducing phaco knife. What's a phaco knife? It's a modified phaco tip which is made up of titanium, which is malleable and ductile in nature, whose beveled distal aspiration port circle is softened first by heating and then closed using the pliers and made into a screwdriver tip kind of form, which is sharp, and its ends are sharp using lath. Initiation. Well, the project was started on Friday, 1st of September 2023, when I discussed my idea with the NIDEC people and procured 3 phaco tips from them. How it's made, the phaco tips bevel distillation aspiration port was first softened by heating. Then it was closed using pliers, and using a lathe it was sharpened. The working principle of phaco knife is essentially the same as the normal phaco, using the ultrasonic frequency and is jackhammer to and fro motion. We can cut through the IOL. With the phaco power of 30 to 40 is effective. The aspiration and vacuum are set to 0. The in vitro effectiveness, this is a video showing the effectiveness. The conclusion, the phaco knife is efficient, safe and cost effective method for IOL removal that repurposes old phaco tips, reducing the surgical waste and the carbon footprints. Its simple modification make it accessible to all surgeons, and you can do it yourself also. So there's no need to throw away the old phaco tips, turn them into phaco knives. These are the future tip designs. The normal screwdriver tip which is sharpened, and the crescent moon tip can also be developed, which will not allow the IOL to slip away. Thank you.
Nega Dolakias is phaco scissors, that is the scissors there.
Sir,
here is only a knife.
Sir, I'm aware.
Yeah.
Of a few months back, I got to know about the same thing. Dr. Jithani told me about it. So it's a long. I think the same idea can come to more than one people, and it's not like there's no scissoring there. It's like it's a knife itself. It's just sliced through it. Yes, sir.
This is a knife which cuts.
Yes, it's a slice. It's a
So
knife.
how much of because the phaco energy is released, no?
Sir, 30, 35, 40. It cuts efficiently, sir.
Okay.
Yes, sir. You have to hold the lens. Right? Yes, sir. We have to hold the lens. I've also used in the eye also, sir. It's very effective. Yes, sir.
With what you hold the lens?
Sorry, sir.
With other hand, you are holding the lens with which instrument?
Sir, any forceps will do, sir.
Microforceps, yeah.
Yes, sir. Yes, sir. Any forceps we can hold
the epsilon, this microforceps is available, which can
Yes,
hold
sir.
lens holding forceps.
Thank you, sir.
Yes,
Thank you.
yes. Very nice. Give the Pratik.
The next speaker is Dr.
Request Sham Sundar to give the certificate to Pratik. Yes, there. Come.
Is Dr. Gopal Pillai here?
Is there?
Yeah, he is there. So he will be talking on point of care test to identify non-responders to anti-VEGF injections.
Thank you very much, and good afternoon. So I would be talking about a point of care test kit to identify non-responders to anti-VEGF. Currently, we know that if you inject multiple anti-VEGFs, then only you will know whether the patient is responding or not responding. And then if it is not responding to anti-VEGF, we may move to alternate treatment like steroids. So can I move to the next slide? Slides, please. Yeah. So we are the Proteomics and Molecular Medicine Study Group, which got funded from Government of India for this. And as our mentor says, you have to always innovate in order to touch 1 billion lives. We know that good, tight, metabolic control, laser, anti-VEGFs, and vitreous surgery are the mainstay for treatment. But we have different types of patients. One type of patients who respond quite well like this, and another type of patient who worsens despite treatment, the non-responders to anti-VEGF therapy, which is about 30%. And we will come to know about these non-responders only after about 4 or 5 injections. So the basic idea would be to find out them in the first injection itself. So you have to store the aqueous samples, and we have to differentiate between the responders and the non-responders. They are stored at minus 70 degrees. And first of all, we thought, whether the VEGF levels were very high in those non-responders, and that is why we looked at the ELISA VEGF levels, and we found out that there was 3 group of patients, one with very, very high VEGF levels of 2,500, which was behaving a little different. But the percentage of those patients were very, very minuscule, only 4%. And then we differentiated the responders and non-responders into 2. One would be, reduce more than 40% of the macular thickness in 4 months. If only 4 injections were required in 6 months, and if all the if patients with macular thickness normalized in 6 months. So these were the responders, and all these 3 were negative. They were called the non-responders. So we have the responders and the non-responder population, and then we looked at the VEGF levels as well as a lot of other cytokine levels. We found out very interestingly, we found out that the non-responders had multiple injections, and so the VEGF levels were actually very low. So the non-responders' VEGF levels are lower than the responders, which means that there is some other cytokines at play, and our next idea is to find out the other cytokines, so and the proteins which are different. So we did a 2-dimensional gel electrophoresis, and here we find out the differences, 5 proteins which are differently there in non-responders and responders. And then we moved into other cytokines with a multi-bead assay flow cytometry, and we looked at about 12 cytokines, and we found out that IL-6 was higher in non-responder, IL-8 was higher, IP-10 and MCP-1 were higher in the non-responders to anti-VEGF therapy. So that was published, and then the next idea was to actually correlate those non-responders to the OCT parameters, because finally OCT-based parameters will give us a non-invasive tool, and so these things were looked at, and we found out that IL-6 were higher in spongy edema, ISOS junction which was disrupted, and drill which was absent, and also IL-8 like that. And then the next thing was the development of a lateral flow kit which takes into account 2 things. One is the protein, which differentiates between the responders and non-responders, and number 2 is the cytokines which respond. So it's a sample pad in which we will write, we'll put it, and there is a conjugate pad where all the chemical reactions take place, and then on the nitrocellulose membrane we will find out whether the proteins are present or absent, or the cytokines are present or absent based on numbers. And so we developed 2 such kits prototypes, and one example I'm just showing you here. So this is this patient with very poor response, and we can sign that the proteins were very high in that particular leg. And here again the cytokines are much higher in this. So the validation is the next tool. So we have used this proteins, and it can pick up the inflammatory cases, and we can use this in 15 minutes. We'll come to know whether the patient is a responder or non-responder in the first injection itself. Thank you very much.
Very nice, Gopal. Very, very innovative. This is only for DME you're doing, is it?
This is a candidate disease, sir. Once we find out DME, similar things can be extrapolated for retinal vein occlusion, branch retinal vein and central retinal vein occlusion, as well as for age-related macular degeneration. But AMD will have a separate set of cytokines and proteins. It will not be similar to diabetic retinopathy.
What is the specificity of this test and sensitivity?
Yeah, so when we looked at responders versus non-responders, to increase the sensitivity and specificity, we did not cut in the center. We took the best responders on this side and the worst responders on the other side, so that it could be more specific and sensitive. But as I said, this is a proof of concept. So once we move to validation with multi-centric study with multiple, maybe more than 200 patients, then only we will come to know the exact sensitivity and specificity.
What about the cost for each
Sir,
patient?
it depends on the number of users. Probably it can be costed at somewhere around 2,500 per test kit.
How many patients have you done like this?
About 80, sir.
80 only.
Okay. Thank you very much, Gopal, and request Dr. Ashok to give the certificate to Dr. Gopal Pillai. You're wearing a nice shirt also, Gopal. Next speaker.
Dr. Sheetal
Sheetal.
Nanaware. Impression cytology for suspicious ocular surface lesions, a modified method.
Good afternoon all. Today my topic is impression cytology for suspicious ocular surface lesion. So there are ocular surface tumors. It can be malignant, pre-malignant or benign lesions, and mostly it is arising from conjunctiva, limbus or cornea. It is mainly from squamous epithelia, melanocyte or lymphocytes, and slit lamp by microscopy, obviously by trained professional, frequently yields a correct diagnosis. So, and gold standard for that it is biopsy only, either incisional or excisional. So coming to cytology, ocular surface cytology, it can be performed by like several methods like spatula scraping, brush cytology or the impression cytology. So impression cytology, as we know, like from different technique, like basically by two, like cellulose acetate filter paper or the biopore membrane device, and like as we know, it is quite expensive. It is coming 2000 to 2.5K both in device and that paper also. What we do in that technique, like basically we will do like with papers, we will touch that conjunctiva or the cornea, and cells will be added to that surface and removed from the eye, and it will be processed further for analysis by various appropriate method for histology, immunohistology or the molecular analysis. So in day-to-day OPD, we can see like many patient coming with pterygium or pterygium mimicking, for example, like OSSN or the multiple ocular surface disorder without any underlying cause or like without determined cause. So for every suspicious case, we can't give antineoplastic agent also because it will be risky because of its side effect, and counseling also cumbersome for sometimes to patients also. It is medication and regular follow-up won't be done by patients, and even to plan for surgery and to wait for result of histopathology, it is also time consuming. So in our study, what we have done, like we have used like it is as we know, it is minimally invasive, innovative, fast and the cost effective. So what we have done like it is patient who are coming to regular to our OPD. We have done in such patient after taking consent from them. We have used like 35 Watson filter paper, what we have used for Sharmas. So and we have taken that filter paper also, and we have taken that smear on slides also, and we have sent to laboratory with they have done fixating with 90% alcohol. So we have done like 15 to 20, as we have started it recently from 5 to 6 months only. So I have done like in 3 cases what we got, like for in first case it was 64-year-old female with status for pterygium excision done. We have collected samples. It was negative for malignant cells, and it was just showed like scattered unnucleated cells. Then patient underwent surgery. It came in biopsy like solar actinic changes suggestive of actinic keratosis. This is post-op pictures. Then one more patient, like 55-year-old male. He had like fleshy growth. We had done sample collection. On that impression cytology, we got low cellularity of scattered squamous epithelial cell and no atypia. And post-excisional biopsy, it came as like CN grade 1. Then one more recently we got in OPD. He had history of herpes zoster, and he has on and off treatment for stromal keratitis also. Like from 1 month he had having some granuloma formation. We also did sample collection. For that no cells are there. We have planned for that patient biopsy and not surgery. So as we can see, in case 1 it was suggestive of actinic keratosis. In case 2 it came like CIN grade 1, and in case 3 we are still depending on like biopsy for confirmation. So coming to conclusion, it is the like novel technique, then it is rapid, less invasive, it is also cost effective, and it can promote like fast innovation for better prognosis. So it is like very simple, easy to learn and handle, and for beginners also they can diagnose, and management also can be done with supervision, and it can be helpful in cutting off the waiting period with histopathology report in early stage. Thank you.
Have you compared this with the established methods of impression cytology which you referred to in your first slide?
No sir, we have
because
just
that is the way you need to compare. No, you're comparing it with histopathology, which is not correct. Impression cytology using Sharma's Whatman paper to impression cytology using the membrane micropore devices and other. That would be a valid comparison. Okay? Thank you.
Certificate, Sheetal. Rajiv?
The last speaker is Dr.
Because
Shweta.
Rajiv to give the certificate to Dr. Sheetal.
Dr. Shweta Walia, modified pulse string suturing technique for amniotic membrane grafts.
So good afternoon, everyone. Though we are moving from towards the sutureless surgeries and towards glue, but many times in government institutes, when glue is not available, we have to continue our suturing techniques, and modifications are needed. We all are doing AMG for as a substrate for growth of epithelial cells, for tectonic support, for conjunctiva and corneal defects. Traditionally, we were using interrupted sutures, and then running sutures in form of purse string came. But we have seen that purse string suture, the AMG is not so tightly secured to the cornea, and many times it loosens up very easily. So we needed a technique which is more stable, cost effective and comfortable. So you can see in this video that we take a bite, and then the second bite is taken a bit away from the first, and then you loop the suture around it. In similar fashion, the bites are taken,
What's happening?
And in the end, the only care that you need to take is that the second bite has to be a bit away. Now, in the last, you unloop it, and in the end, when you will pull the suture, all the knots will be gone. So I'll show you the video, how is it done. So we take a bite. The second bite is taken a bit away, posterior to the first bite, and you loop the suture around it. So you have taken bite, and the second bite will be a slit posterior to the, from where the suture has come out. So we have come to the end from the starting point, and now you have to just unloop it. All the loops are unlooped. And when you will pull the suture, the entire suture goes beneath the amniotic membrane, and you can see how snugly it is fitting onto the cornea. I had done this technique in about 12 patients, and the post-operative comfort to the patient is excellent, and it gives better attachment and stability, and it definitely can be explored by many of us. Thank you so much.
Very nice. What suture you are using? 10-0? 10-0 what?
Nylon.
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 Okay.
For cornea and conjunctiva, nylon is preferred over the vicryl. Vicryl has tendency to give more inflammation. So we are using for conjunctiva and cornea, nylon suture.
Any questions from anybody? From the audience, any questions? Yes, madam. Yeah, another 1 minute. Oh, running late already. Yeah.
Ma'am, it causes inflammation. We don't use for ocular surface is already disrupted. There is inflammation. Vicryl sutures are preferred for conjunctiva and cornea, and there is no problem in putting nylon suture. You can use 1 or 2 sutures, and that you will remove after some time. But when you are giving a full round, in that it should nylon is preferred.
We have come to the end of the session. I think all the speakers were really fantastic. I should give a big round of applause to them, and I request Dr. Quresh to give the certificate to Dr. Shweta. Well done. I'm sorry. And all the speakers to come forward. We'll have a group photograph together. And certificate of Ashok Nanda, please come.
session.